ఇదేది
సెంటాక్విన్ లైఫాక్విన్ అని
నేను ఒక కేసుకు వాడాను అంతే. ఒక్క కేసుకు వాడాను. ఆడ శాంపుల్ అడిగాను, చూశాను అంతే.
డెంగ్యూ పేషెంట్ కేనా?
లేదు,
ట్రామాగా
షాక్ లో ఉన్నాడు పేషెంట్. సో ఫ్లూయిడ్ రిససిషన్ ప్లస్ వాసోప్రెసర్స్ కి ఏదో ఆల్టర్నేటివ్ అని చెప్పాడు కదా అని వాడాను, కానీ నాకు పెద్దగా డిఫరెన్స్ కనబడలేదు.
రెస్పాన్స్ రాలేదా?
అంటే లేట్ గా వాడుంటానులే, పేషెంట్ డెత్ అయిపోయింది.
ఇది డెంగ్యూలో వాడు సెంతాక్విన్ వాడు ఏదో ప్రోటోకాల్ పంపాడు, మరి అది ఎవరు వాడుంటారులే, జస్ట్ రీసెంట్ గా వచ్చింది.
అంటే రిజిస్ట్రేషన్ కి నా ఆప్షన్ కదా ఆల్టర్నేటివ్.
అదే ఎప్పుడు ఇవ్వాలి అన్నది వాడు ఇది ఇచ్చాడు. అది జస్ట్ ఐ విల్ షో దట్ విల్ డిస్కస్ లేటర్ అట్ ది ఎండ్ ఆఫ్ ది సెషన్. చెప్పిన వీళ్ళకి ఏమన్నా మోహన్ సార్కి లేట్ అయింది కదా? ఎంతమంది వచ్చారు?
జేసీనోస్ చేస్తున్నాను.
Nation's landmark with your support and your effort.
Good morning, sir.
Sir, good morning.
Yes, sir. Morning, sir. Morning, sir.
Good morning, sir. Satish.
Sir. All right. Synos kuda ready. Start cheyandi.
Okay.
Start cheyadama, David.
Okay, sir. Good morning, all. Welcome to this today critical care webinar. As we are facing in a high mortality regarding the dengue patients, particularly patients are presenting with fever and thrombocytopenia. Some of the patients are drastically deteriorating without any signs. So they are deteriorating and dying very, very rapidly. So in that context, we would like to present our case scenario. We had almost 5 to 6 deaths of dengue patients presenting in a stable condition and deteriorated very rapidly. And actually what is happening to these patients, I would like to share my experience to our Morton team. Maybe it's not moving. Okay. 28 years old female with no comorbidities present to ER with complaints of high grade fever associated with myalgia, pain abdomen and vomitings and nausea. She had a fever since 5 days. For that, she underwent some investigations at outpatient basis at Gazuvaka, and she had severe headache, pain abdomen, and syncope with reeling sensation since 3 days. So initially, patient taking some treatment at OP basis. Later, due to worsening of her symptoms like vomiting, pain abdomen, and severe headache and reeling sensation, she admitted in the hospital at the 21st October, and she was fluid resuscitated and gave some symptomatic treatment. and labs are showing as follows, the outside hospital. So blood group was O positive, B positive, dengue NS1 positive on 19th October, HB11, TLC 5,600 and platelet counts were 2,18,000 and RFT, LFT were in normal range. Our platelet counts in the series of from the day 19th, day 19th 2.18 lakhs and the 21st 73,000, on 22nd 59,000 at the morning and evening around 33,000. So our ultrasound abdomen shows outside the gallbladder wall edema, mild ascites, mild hepatomegaly, and grade 1 hepatic steatosis. So as patient condition was deteriorating on 22nd by decreasing urine output and increasing the reeling sensation, worsening vomitings and pain abdomen, and worsening in thrombocytopenia, the hospital advised to go to further higher center for further management. So patient arrived at ER on 23rd at 12:30 a.m. At the initial evaluation, patient was conscious, coherent, BP is around 100/60, and she is maintaining saturation of 100 on room air. So she held mild febrile at 100 degrees Fahrenheit, heart rate 104, respiratory rate was 21. So she was sent an ABG, secured IV cannula, and routine lab investigation was sent, and blood cultures also sent. The fever profile was sent. ABG was done. ABG shows metabolic acidosis with respiratory alkalosis and hyperlactatemia. This is the ABG. ABG was showing 7.36 pH, PCO2 22, PO2 98 on room air. Bicarbonate is 12, basics is -10, sodium 130, potassium 4.8. Blood glucose is 14 millimoles, that is equal to around 270, and lactate was 5.1. This is the ECG, is sinus tachycardia, right around 100, normal ECG. So patient was fluid resuscitated initially and then shifted to ICU and transfused 1 unit of SDP as patient platelets were dropping up to 33. So screening echo was done on that time, but it was showing good LV function. IVC was collapsing. So then the fluids were continuing. Blood and urine culture were sent, police catheterized, and the antibiotics were started, and the antipyretics, BP, and other routine symptomatic management was given. Our lab investigations revealed total count was mildly elevated to 11,000, and platelets counts were 51,000 after transfusion of 1 SDP, procalcitonin 1.1, and peripheral smear suggestive of the viral infection. So our LFT was deranged, and again IgM was repeated. Dengue serology was repeated, and IgM and NS were positive. PBCMP is negative, and scrub type was also negative. This is the investigation chart. 15.9. WBC count is 11,000. Here platelets counts are 51,000. Sodium 152, potassium 5.4, and bicarbonate here 31 in the lab. ABG it is around 12. LFT showing bilirubin 1.5 and direct 0.71. SGPT 497, SGOT 1,490, and total proteins are 4.2, albumin is 1.7. LDH 2,880 and CPK 2,986. Urea 18, creatinine 0.86. HbA1c 7.0. So patient was diagnosed as dengue fever. Later, after fluid resuscitation, patient started developing hypotension, and she was put on inotropes like noradrenaline, followed by vasopressin, as patient is not improving with noradrenaline. Later, testosterone hydrocortisone was started, and then patient had oliguria He passed around maximum 100 to 150 ml in 4 to 6 hours of time. Then ABG was repeated. I will show you the ABG. That time the pH was 7.614. This is the ABG done around 8 o'clock in the morning. Patient shifted to ICU around 2 o'clock, and in casualties he admitted around 12:30 a.m. So at 8 a.m. the ABG 7.64, PCO2 is 30, and PO2 121. Bicarbonate is 31, which is almost equal to the lab bicarbonate. And sodium 152, potassium is 5.4, lactate was increased to 6.7. Can anybody tell the validity of this ABG? Patient in shock, high inotropic support, and previous ABG is showing night around 1 o'clock. It was metabolic acidosis there. Pardon? Anybody respond, please? Validity of the ABG.
Residents, please respond.
PCO2 pH లేదు కదా సార్.
pH is 7.614, PCO2 30, PO2 121, bicarbonate is 31. So after checking the ABG, I thought of repeating this ABG because the ABG is almost normal.
రఘు ఉన్నాడా? రఘు శ్రావ్య అదే చెప్పండి, ఫార్ములా చెప్పండి.
Is it validated or not? That's all. If it is validated, I don't repeat, because if it is not, then I have to repeat this ABG. Raghu?
Not validated కదా సార్.
Yes, sir?
Not validated కదా సార్.
Okay, it is not validated, and this thought it is wrong ABG. Then I repeated the ABG. That time, put arterial line and central line, and this hemodynamics are like this. Almost absolutely like normal. See the NIBP, it is 36/18. Now after starting inotropes and arterial line and central line, connected this inotropes to the central line, that hemodynamics are like this. So very good.
BP pulses, BP
Yeah.
tablet. BP
The ABG was repeated within half an hour. pH is 7.34, PCO2 22, PO2 is 152 on 15 liters of NRBM. Bicarbonate is 11.6, basic is -12. So this is the correct ABG. Now it is validated. Sodium 137, potassium is 5.6. Here in the serial ABGs, potassium is going up and lactate was 7.2. Lactate
sorry to interrupt. What is the H plus value coming in the previous ABG?
Evana?
What is the H plus value coming previous ABG lo?
Yeah, it is I validated, and it is around 48. It is 36. So it is not validating.
Okay, fine.
Almost equal to plus or minus 1 or 2, no? But it is 48, 36. Too much difference.
So bicarbonate was given in the year because both bicarbonate of the lab and this is increased last ABG.
Correlating. Yeah, that's what initially I thought maybe might be correct, but after validation of ABG, it is not validating.
So bicarb is given there in the year?
Before bicarbonate was given, maybe immediately after 5 minutes, might be.
డేవిడ్ ఎవరో రవికుమార్ సురేష్ కుమార్ స్పీకర్స్ ఆన్ అయ్యండి.
Okay, fine.
Okay. Now this is the ABG after half an hour. As potassium is going up
Can residents
metabolic acidosis. In a due course of
Can anyone
treatment.
Anna,
Can I go ahead? Hello? Hello?
show the monitor.
This is the monitor.
Can residents identify this blood pressure? Anyway, there is varying between manual and invasive. Can you see something interesting thing in this? Invasive blood pressure, systolic, diastolic map, anything? Any comments? సెప్సిస్ కి దీనికి ఏం తేడా అసలు ఉన్నారా ఎవరైనా?
ఎవరు మాట్లాడలేదు.
వైట్ పల్స్ ప్రెషర్ అండ్ నారో పల్స్ ప్రెషర్.
ఇప్పుడు ఎంతున్నది?
స్టార్ట్ చేయి, పైలి వద్దు. ఓకేనా?
సో హియర్
డిఎన్ఎస్, నార్మల్ డిఎన్ఎస్
44 45 sir.
జిఎన్ఎస్ మళ్ళీ మార్నింగ్.
No, so as Pratisha was mentioned, it's a narrow pulse pressure is present here. So if you see in the sepsis patients, it is 136 by, ఇప్పుడు 136 ఉంటే ఏదో 50 or 60 ఉంటుంది blood pressure. Here is 136 by 91 is there. So here it is little not as dilated like a sepsis patient. Okay.
Okay.
Any comment?
Later. Yeah. We will discuss about this later.
Yes.
So, in the due course of treatment, patient was deteriorating in hemodynamics, and she was put on NIV. Before putting NIV, she had bradycardia, followed by immediately tachycardia up to 150, 160 heart rate. Then we did echo, and echo was showing global hypokinesia with severe LV dysfunction. Just half an hour, 45 minutes before that echo was completely normal and with IVC collapsible. Now, later, after developing brady, tachy type of arrhythmia, then she had a severe LV dysfunction with EF of 20% only. Then we called cardiologist. Cardiologist confirmed and started some cardioprotective medication. In view of worsening potassium and decreasing urine output, nephrologist was called and he advised CRRT. Gastro was referral given. They advised some liver protective drugs like. Then the ECG was showing. Can anybody identify this ECG? What is the difference between previous ECG and ECG now? This is after developing severe LV dysfunction. Raghu.
Sir, adi
8 ECG. Huh? Any comment?
deep S waves ఉన్నాయి sir.
Okay, this ECG, if carefully observe, there is a small R wave in the anterior leads and there is a poor R wave progression due to dilated LV and severe LV dysfunction in the anterior leads. So then the diagnosis was the dengue shock syndrome, viral myocarditis with severe LV dysfunction, AKI, hepatitis and tachycardia syndrome due to severe LV dysfunction and myocarditis. So patient was on NIV. This ABG was repeated after 1 hour after NIV. This is worsened further. pH is 7.18, PCO2 11, PO2 209 with the FiO2 of 0.5. Bicarbonate is 4.2, base X is -24. Sodium 139, potassium 5.6. This lab potassium at the same time is 6. So she was started on CRRT, and as worsening hemodynamics and worsening of metabolic acidosis and lactate, she was intubated. After seeing this ABG and worsening of hemodynamics. After intubation of half an hour after intubation, patient suffered cardiac arrest and could not be revived with CPR and declared death after 14 hours of admission in our hospital. So blood cultures were sterile so far and reports were awaited. And this was a case when we received hemodynamics were almost near normal, and except thrombocytopenia, mild metabolic acidosis, There was no complaining of breathlessness or anything. She had a pain abdomen, vomitings, and some giddiness. And we lost that patient within 14 hours. Thank you all. We will have a discussion after finishing Dr. Satish case. And I welcome Dr. Satish to start your presentation. Thank you. Anna,
డేవిడ్ కంటిన్యూ చేసేద్దాం డిస్కషన్.
నీది స్టార్ట్ చేయి, తర్వాత కంటిన్యూ చేద్దాం.
టైం పడుతుంది.
David,
because there is a
I missed the last few minutes. Sudden గా కనెక్ట్ అవ్వలేదు, మళ్ళీ ఎంటర్ అవ్వడానికి అవ్వలేదు. ఆ కంక్లూజన్ ఏంటి చెప్పరా మీది ప్లీజ్.
కంక్లూజన్ లేదు, పేషెంట్ ఎక్స్పైర్డ్.
Anna, David, as Satish sir mentioned, because fever prodromal the time పడుతుంది, at least it will take 40-45 minutes. అవునా sir?
అవునా.
So let's discuss on this case, our experiences, and then next week okay na sir మీకు?
సతీష్ రెడీ అయిపోయాడు. సతీష్ రెడీయా? సతీష్ నెక్స్ట్ వీక్ చెప్తారా?
చాలదేమో సార్
టైం పడుతుంది.
నెక్స్ట్ వీక్ చెప్దామా, ఇది డిస్కస్ చేద్దామా?
డిస్కస్ చేద్దాం.
చెప్పండి సతీష్, లెట్ సతీష్ డిసైడ్ బికాజ్ హిస్ టైమింగ్ ఇస్ ఇంపార్టెంట్.
విల్ పోస్ట్పోన్ సార్.
Okay, right. Go ahead with the discussion then. Because I'm very keen and interested about this because recently 2-3 more cases came. They survived. Very early signs elagani cheppi chusanu. So andukosam very close. Enante every 12 hours compulsory investigation cheyinchanu. All 4 investigations like lactate, platelet, LFT and bicarb. So ivi compulsory every 12 hours cheyinchanu nenu. And platelet count fell to 6,000. So after 6,000 falling of platelets, immediately we checked with the pathologist. So it was around 17,000. We did not transfuse anything, even with 6,000. The only thing is we looked into the giant cells availability are present. So once the pathologist told giant cells available, we did not do anything because what I have noticed with our friend of, once you give your platelets transfusion, the immunity levels are still going down. So we don't want to give unless there is any bleeding tendency or there is a clear-cut indication. Actually, we supposed to give below 10,000, but we rechecked it. It was around 16,000, so we did not give. Anyway, that's how. Yes, I.
So here, we recently participated in one webinar from Apollo Chennai ID group. So what they mentioned, throughout India, there was a problem with one serotype 2 dengue and Asian genotype 2. These two were identified in present dengue season. These two carries very high mortality. These two carries dengue shock syndrome with multi-organ dysfunction and rapid deterioration and death of the patient. So we can prognosticate if we identify this serotype and genotype, but it is not possible in our setups. It can be done only in Pune and CMC Vellore. Anybody have idea about these two things?
No, sir. No, sir. I don't have idea. But I can tell few things. What I should have done in this patient is one is if the patient is on higher end and vasopressors, like the patient is on noradrenaline and vasopressin, early intubation is one of the things where we can even take out the respiratory muscle utilization and having more lactate production. One. Second thing is give a fluid resuscitation as much as possible. But
patient intubated just in the morning around 10:30.
Yes, sir. This patient came at
but not delayed actually.
And 12:30
placed after 1 hour intubated.
ఎందుకంటే యూజువల్ గా మేము వాట్ వి డూ ఇస్ విత్ పేషెంట్ ఈజ్ ఆన్ హై డోస్ ఆఫ్ vasopressors, we intubate the patient because these patients suddenly collapse. And then hemodynamically unstable anpiste. Then these patients anyway acidosis will be going on increasing. Once the acidosis base excess is little higher, we should start on CRRT because these are the patients they don't give time. And if the patient is and these patients go hello these patients go into ARDS, and we should be ready for if the affordability is there. If we should be ready for ECMO also.
Yeah, ECMO anyway we don't have that facility, but we have intubated and did CRRT also. But the patient was deteriorated very rapidly. Half an hour before the LV function was normal, and within half an hour immediately the LV function, because she developed brady suddenly, we did echo severe LV dysfunction. So we recorded both. I could not show here.
So even not much tachycardia also, no, sir. It's only 105, 110.
Later she went into tachycardia, 150, 160.
So we see that the heart rate also doesn't go more than 120. To add ivabradine is one of the safer side. This is my understanding.
Will you add ivabradine when patient is having high inotropic support?
Yes, sir. Because these patients, we add ivabradine.
What is the use if patient have severe LV dysfunction with the tachycardia?
Now what happens is, as you mentioned, the tachycardia is maintaining the cardiac output.
Yeah.
Okay. So with a severe LV dysfunction. Now the second thing is the tachycardia itself is increasing the cardiac demand. Again, the heart, if a patient having a tachycardia more than 120, we don't have a whatever is the diastolic thing will not be there. So if more than 120, there is no much use of cardiac output may not increase much. That's the reason why keeping between 100 to 120 is better, but not all the patients. This type of patients.
Patient in shock, do you think ivabradine tablet will act?
We don't know. Absorption anyway will be less, but we can try it.
Okay.
We try it.
Right. Yes. Any suggestions or doubts from audience or your experience? What we observed in this case are another 3-4 cases. Creatinine was normal. LFT was deranged. But patient developed oliguria followed by anuria. Hello?
David.
Because of hyperperfusion, kada, David? LFT deranged because of hyperperfusion, kada?
Because LFT is immediately showing in the labs, but creatinine was not elevating. It may take time.
To become creatinine to elevate, there should be 30% of destruction into the kidney function. Then only the creatinine will raise, no?
It may take time, some more time to develop raise creatinine.
Sir, anyway, it will be fitting into rifle criteria or EPIC criteria, no? Kidgo criteria, because urine output is less.
Yeah, you not put fitting.
Yeah.
Chat box lo Shravya has a question.
Yes. What is that?
Why is the microcirculation very difficult to manipulate in dengue shock syndrome, and how can it be optimized as much as possible, in particular with dengue patients? Some patients will deteriorate with lactate worsening despite fluids and aggressive vasopressors. From Savia.
Anna,
that question అర్థం కాలేదు సార్. సరే నేను డ్రైవింగ్ చేస్తున్నాను, ప్లీజ్ ఒకసారి చదవరా.
Why dengue patients are not improving when they are in shock even after fluid resuscitation and vasopressors?
Okay. So it is like any answer from you, David sir?
ఏంటిది ఎనీ మళ్ళీ ఒకసారి
Why the microcirculation is very difficult to manipulate in dengue shock syndrome?
because it is a very severe leaky syndrome, severe vasodilatory shock. Patient, if you give too much of fluids, they are going into third space loss, even pulmonary edema, and that type of complications without improving the perfusion pressure. Even they are not responding with hemodynamics. With inotropic support and testosterone also. So we are out of this thing, and we can, whatever you are doing, a patient is not responding. That's why I would like to show this for maybe alternate answer for her question. This is the pathogenesis of the dengue shock syndrome and dengue hemorrhagic fever. When there is an increased vascular permeability and the severe leakage of plasma and proteins into third space, patient is going into shock. And organ hypoperfusion, progressive organ impairment, and refractory metabolic acidosis associated with plus or minus DIC. And because of the refractory metabolic acidosis and persistent shock, patients are going into MODS, multi-organ dysfunction, like severe hepatitis, AKI, ARDS, encephalopathy, and myocarditis. The refractory shock, multi-organ failure, and death. This is the patient pathophysiology. Whereas the lifoxin people, like the Syndromic recently coming into the market, they given one protocol in a dengue shock syndrome and dengue hemorrhagic fever. There are two types. One is compensated and one is persistent shock. Initially, they advised to give fluid bolus and 10 liters per kg per hour in 1 hour. If there is a improvement, then okay, you continue on crystalloids and the further management. If there is no improvement, check the HbPCV like HCT. If the HCT is increasing, but patient is further hypotensive, give second dose of crystalloids like 10 to 20 ml per kg per hour for 1 hour. If the HCT is falling, then check any overt bleed or bleeding in the abdomen or somewhere else, then give blood and colloids like that. But if there is no bleeding and HCT is increasing, then what they advised, to give 10 ml per kg per hour for another 2 hours. If the patient is not improving, then after second dose of fluids, then they advised to give lifoxin, that is Syndromic. Here they advise second persistent shock. They advised to give, previous slide they advised to give 20 ml per kg. Sorry, 10 ml per kg. Here they advised to give 20 ml per kg over 15 minutes. Means rapid fluid bolus. And second dose also around 10 ml per kg in 30 minutes. If there is no improvement, again they advise to give Syndromic. So the Syndromic is a alpha 2 blocker and alpha 2b and alpha 2a. Alpha 2b will increase the preload and push the blood towards the heart to increase the stroke volume and blood pressure. Whereas alpha 2a blocker decrease the afterload and increase the cardiac output. So overall net result is improving the blood pressure, perfusion pressure, and increasing the vascular integrity and decrease the loss of fluid into the third space, thereby improving the hemodynamics and perfusion and decrease the multi-organ failure. How Syndromic will be given? It takes 10 ml of normal saline into the vial. Then don't shake it. Just then after 5 minutes, take this fluid into 100 ml normal saline. Can be given over 1 hour. So I don't know whether it works or not. Now they are coming with this management. If anybody have this experience, please you can share your experience. Anna, anybody?
No, we don't have any experience with Syndromic.
Is it
It's also
logical
costly.
or any rational in this?
Huh?
Or any evidence for this treatment?
Yeah, very less, not much.
Less means
And it is
there?
costly also, no? It's costly 60 or 70,000, no?
Yeah.
Uh,
No, once a patient is dying in front of your eyes within a few hours, why don't you try?
that's where all the pharmacology companies pitch, no?
No, whatever it is,
Ade,
we are doing so
they
many
have money, we can try.
manipulations. No? Huh?
If they have money, we can try.
They are ready to spend. People are dying in front of your eyes in shock. So that is not the issue of trying, but evidence is less.
Sir,
And I asked about this. I asked about this molecule in ID people. They said it. They don't have experience also.
Yeah. Most of them doesn't have experience, but few hospitals are using it. Actually.
Trying.
And also, when this type of costly treatments should have a minimal evidence when we give to the patient.
Anna, please talk loudly.
Because the side effects also we don't know at present. Unless you use more, we won't be knowing.
Satish wants to tell.
No, I have few doubts about the pathophysiology in dengue, and so when the diastole is reasonably good, we are talking about it is around 90 initially, and there is a narrowing of the pulse pressure, and the capillary leak syndrome, sepsis is there, dengue shock syndrome is there. How they are different now? Because
No,
ultimately,
actually,
unless
that is the is your doubt because of there is a narrow pulse pressure not fitting into vasodilatory shock.
yeah,
Later, after 15 20 minutes, this is the initial hemodynamics after starting narrowing and vasopressin and gave some bicarbonate. So later, within 15 minutes, our diastolic pressure gone down to 40-45. And BP is around systolic around 100-110. Diastolic is 40-45. I didn't show that one. Yeah. Maybe that transient response of noradrenaline and vasopressin both are increase the afterload, no? So maybe transiently the diastolic pressure has elevated, then it is fell down within 15 minutes.
No, my question is, in septic shock, there is a capillary leak and there is a low diastole. We fill the compartments in a bolus doses. In these patients, there is a narrow pulse pressure. In septic shock, it is clearly known that it is a wide pulse pressure. Whereas in these patients, particularly these dengue shock syndrome or any tropical fever related issue, they clearly say that there is a narrow pulse pressure. When it is a narrow pulse pressure, still we call it as a capillary leak syndrome, and we are still giving fluid resuscitation and vasopressors. I think that there is some disparity in the both.
Sir, we see here what happens is pathophysiology is little different from septic shock. The septic shock is a release of vasodilators and leading to a vasodilatation condition. So the diastolic pressure will be falling down. Here, there is a vasoconstriction and capillary leak is there. How will you know this patient? And also, there are two things are here. One is tissue perfusion is compromised severely here when compared with septic shock. Septic shock, of course, when go into the not in the early stage, in the late stage of where we see that there is a coagulation changes and platelets start dropping. There will be a lot of compromise. Here, this will be early because all the platelets are activated. There is a capillary leak and there is also a compensatory mechanism going on in the body to have a coagulation. So these are blocking the capillaries, end capillaries more, and that's the reason why the lactates and metabolic acidosis increases more in these dengue patients. even though they look fairly well, but here the lactates and metabolic acidosis will be very high. Second thing, how do you resuscitate this patient? This resuscitation of these patients depends on the pulse pressure. If the pulse pressure is very narrow, you give a high amount of fluids. If the pulse pressure is more, you don't give a more this one fluids. But ultimately, fluids has to be seen not depending only on the pulse pressure. You also has to look into the other parameters, and we have a lot of hemodynamic parameters where we can look and give it to it. This is my thing.
But in this case, almost till the end, lactate is well maintained and oxygenation is well maintained.
Lactate is very high since admission, no sir? This patient?
No.
David sir?
David.
Only. Lactate was high from the beginning.
Yes.
5.6, later 6.6, later 7.1, later 12. So repeatedly it is dropping.
Yeah.
Almost we did ABG every 2 to 3 hours.
Okay.
Worsening metabolic acidosis, worsening lactatemia.
Yes.
Initially, it was not that bad. No, 7.36 or something you told me at admission.
pH.
Initial admission itself is 5, I think, no?
5.6.
What?
5.
Lactate.
Lactate,
Yeah.
yes.
Okay. So whatever it is now, my take home in this thing is, if the patient comes to us in a later stage of dengue, when everything is established, complete shock syndrome, it is difficult to revive, sir. So hematocrit is the one thing where we really look into the worsening of the hematocrit, that is hemoconcentration is happening, and by the time already patient received enough fluids, and in the further fluid load will lead to third space leakage and compartmental syndrome. That is the place where we are going to lose the patient.
Yeah, actually, this patient definitely on 19th she had symptoms and she admitted here in the 23rd early morning. Maybe 4 days delayed. Majority of the patients coming to higher centers, immediately they don't come now with fever. Usually, nobody will.
Nah, good thing is if they don't admit in the early stage only is better. Early stage in the sense fever angle admit out there. This patient inevitably, if the patient is admitted in the hospital, also is going to collapse because they won't respond.
Correct.
So most of them, what they are doing is when their platelets are started to come down, they are admitting. Physicians are admitting. There's a right time to admit also, but needs to follow blood parameters and needs to look into the how high is the fever, hydration is actual is normal or not. They need to address it, physicians.
Because we don't know which patient having this serotype or genotype infection, so they are unable to differentiate these two. So that's why their resuscitation, all these things getting delayed, and they are landing into this very.
I think a few more questions you have, no sir. How do you resuscitate? Can we discuss on the questions?
Yes, sir.
ఏమన్నా ఇంకా క్వశ్చన్స్
లాస్ట్ స్లైడ్ లో పెట్టావుగా ఏదో
రిక్వెస్ట్ ఎవరీవన్ టు స్టాప్ ద స్పీకర్స్ అదేంటి స్పీకర్స్ ఓకే ఆ స్పీకర్స్ నారో పల్స్ ప్రెజర్ అండ్ ఆ అమ్మాయి అడిగిన క్వశ్చన్కి అయిపోయింది కదా ఇంకేంటి ఇంకేమున్నాయి M. Srinivas is there. I think M. Srinivas and Mohan sir have more experience on dengue with these patients. They can advise or comment on this.
No, you have put a last slide, no? Some questions you have put 4 or 5 questions. Let's see that question.
ఆ క్వశ్చన్స్ ఏం లేవులే అన్న, జస్ట్
ఇంకా పైకి ఇంకో స్లైడ్ ముందుకి ఇంకా
how to treat refractory shock. So how will you manage a deranged coagulopathy and raised LFT, RFT and worsening of refractory metabolic acidosis. So this is the problem with the dengue. So that is the main issue.
మీరు అడ్రస్ చేయగలుగుతారా సతీష్ సార్ ఇన్ దిస్ ఆస్పెక్ట్స్ దిస్ క్వశ్చన్స్?
సార్ బేసికల్గా ఏంటంటే వాట్ ఎవర్ వి డిస్కస్డ్ ఇస్ అల్టిమేట్లీ ద ఓవరాల్ derangement the hemodynamics, sir. Why these hemodynamics, sir? It's like it's multiple factors are playing here. One is, as you said, it is a capillary, like initial vasoconstriction followed by capillary leak followed by metabolic acidosis worsening the system again, myocardial depression, decreased renal functions, decreased liver function, again it's a cascade, again it is hitting into the internal environment, and ultimately it's a vicious cycle and we are not able to break that shock. So all are on principle, what I feel is because once it is completely established, no, I think as of now the available literature and knowledge, we are not in a position to put a break to this cycle.
ఉన్నారా మోహన్ సార్ అండ్ ఎం శ్రీనివాస్ ఉన్నారా?
వరలక్ష్మి, రాణి మేడం,
వరలక్ష్మి, రాణి మేడం ఉన్నారు కదా.
ఎం శ్రీనివాస్, they are not responding.
How to treat worsening metabolic acidosis in hyperlactemia, not responding to bicarbonate.
కాదు ఇప్పుడు ఎవరు మిగిలిన వాళ్ళు ఎవరు సీరియస్ మాట్లాడలేదు డేవిడ్ ఏంటి?
అదే మాట్లాడలేదు మరి ఏంటో.
Akshit, there is a question. How to treat worsening metabolic acidosis and hyperlactemia, not responding to bicarbonate, even dialysis? I mean, CRT was also not much helpful due to hypotension. Akshit has posed this question.
Any answer from seniors?
No, Satish sir,
I think ECMO is the only solution for this.
See, this is because of the multi-organ failure is linking because of hypoperfusion. That's the reason why it is having metabolic acidosis and lactic acidosis. The only thing is we need to address adequate fluid resuscitation and disease process decreases only, it will come down. We cannot selectively decrease the metabolic acidosis and lactate. It's a disease process.
So in spite of going for CRRT, all these things, can we put them on ECMO early?
Sir, ECMO, the issue here is, here you have a problem is mainly hemodynamically problem. Most of the time what happens is, just my brief knowledge on this, patient is having hemodynamically instability. It's very difficult to put these patients on ECMO because we want to go on a VA ECMO.
Yeah, VA.
Now here what happens is, if you give more fluids, resuscitating this patient, all these things, then these patients will go into ARDS, where the hemodynamically little becomes stable. Then there's a time where the PCO2 starts increasing, the PO2 starts decreasing, severe ARDS, higher settings. That's the time where we can go into the ECMO. ECMO is, as you mentioned, ECMO is not a solution for this, but the time gap is extending the life so that patient can improve.
Yeah. Madam.
David, ECMO pette already they are in acidosis coagulopathy, they'll get worse kada. How can we put ECMO?
Because there is no option. Anyway, patient is dying.
Yeah, maybe FFPs and coagulation factors, plasmapheresis and CRRT. Maybe those things we can try and do. I mean, like as soon as you see the signs of going down, like as you said, lactate going down, going up, and metabolic acidosis worsening fast, and quick decision to do CRRT, plasmapheresis, maybe
Done,
those
madam.
things may help.
Done, but not responding. That is
Yeah.
also.
In
Madam,
our
one
case
question.
also we have done. In our case also we have done, but lactate gone from 6 to 10 and then 16 within few hours. Yeah.
Yeah.
Madam, you good morning, madam.
Morning, morning.
Lakshmirani madam. Bagunara?
Morning. Oh, fine, thank you. Chappandi.
Madam, ఇది how you are seeing lot of patients kada, Mohan sir gaani, David gaani, meer gaani, lot of dengue patients. How many of the patients you are seeing less than 20,000 or 10,000 patients bleeding?
No.
Not even single patient.
No, not many. Like 2-3 patients, they had melena, they had really bad purpuric rash. So melena we have seen. Melena we have seen like a little bit streaky and the vomitings that we have seen, but that's not clear GI bleed. But melena we have seen, that's GI bleed, right? And even they say low platelets with a lot of purpuric rash, that's also indication that they are going into bleeding manifestation, right?
Yes, madam. So
yeah.
basically these patients bleeding chances are very less, and so we can safely go, madam. That's the last option, because we don't want to a deathbed నుండి ఏమైనా బయటికి తీసుకురాగలుగుతామని ఆప్షన్ అంతే.
అంతే. What about like steroids? I've seen, I mean, there's no role of steroids in dengue management, I know, but some of our clinicians, they're writing dengue when the platelets are like in 20,000-30,000 like that. Is there a role? I mean, we give when they are on dual vasopressors, refractory shock, but clinicians, physicians, they are putting them on steroid as well. Is it justified, or do any of you doing that?
No.
No, madam. We are not at all giving. Even 5,000 platelets also, we are less than 10,000 only we are transfusing, and we are not seeing even less than 5,000 platelet count patients are bleeding. As you said, there is some lower GI bleed or some melena or in vomiting some streaky blood, but they are given transfused some platelets, but we never give steroids to any patient.
David sir, just
Yes,
wanted to add
Srinivas.
some points.
Yeah.
This is regarding the refractory metabolic acidosis and hyperlactatemia. And when there is a refractory metabolic acidosis, normally we give bicarbonate infusion or boluses. But problem is it worsens the lactatemia. So we have, because the pathophysiology over here is because of the perfusion or the volume issues, not because of other issues. Second, the volume issues and the increased permeability is because of the antibodies, high level of antibodies, and secondly because of the cytokines. So like aggressive removal or early removal of these antibodies may stop the pathophysiological process, ongoing process. Maybe CRRT and plasmapheresis might be helpful in CRRT in the sense not only effluent management, but using a cytokine removal filter, either cytosorb or oxalis or some kind of filter. You have to decrease the load of the cytokine so that your permeability decreases and your third spacing decreases. Then your acidosis gets corrected. So that is the only thing. But which patients we have to start early, that we can't define exactly. And the lactatemia, one because of our liver function derangement, and secondly because of our excessive use of bicarbonate. So those things can will worsen the lactate levels. And regarding the ECMO, yes, definitely there is a role of ECMO when even in coagulopathy we have to go for ECMO when the patient is in cardiac dysfunction with refractory shock. We have to use a if you want to support the patient till its recovery, we have to go for it.
There is a question here.
Yes.
Akshit. how to manage coagulopathy? Should we check for individual factors? Should we replace individual factors? I mean, will it help anyway in any one of the patient?
Sir, better rather than platelets and PTANR, if the patient is severely deranged coagulopathy with a liver dysfunction, it's better to go for TEG, going for multiple transfusions and requiring multiple transfusions. So TEG might give a better idea.
Grossly speaking, anything like check the fibrinogen if it is in the DIC, if it is less than 150 or something, give cryoprecipitates, whatever that is available, because the availability of components is difficult. To start with platelets, then with FFP, then with cryoprecipitates, that we can escalate our component replacement.
Usually in dengue shock syndrome, unless patient is having bleeding tendency or coagulopathy, almost 99% of these people don't have any bleeding issues.
No, we are what we are talking about is about a severe patient who was on ventilator with severe DAC. Those patients has to be.
I agree with both actually, both Satish sir and Srinivas, because one, we need to know the numbers. What are the numbers for fibrinogen, PTA, PTT, INR, and all these things. As per that, we will do correction, and also TEG gives lot of insights into the coagulation management.
Yeah.
Okay. Any experience or doubts? If there are no, shall we stop?
Yeah, the thing is, David.
Yes, sir.
ECMO role ఏం చెప్పారు?
Yeah, ECMO. Yeah, finally, after trying all these things, coagulopathy is not the issue because these patients will not bleed like other patients. Can go on ECMO if there is no alternate.
Patients in ARDS, patients in severe cardiac depression with refractory shock, we have to go for it.
Who requires a cardiorespiratory support, both VA, ECMO, initially to start
Not for this leaky syndrome or multi-organ dysfunction.
So one thing is, David. One thing is like, don't take dengue patients light nowadays, because as you said, the strain has changed, and this time this epidemic is because of that new strain, something like, I think it is 4th strain. What is that strain you were telling?
It is serotype 2 and Asian genotype 2. These two strains.
So the same thing, no? The Dr. Suresh, ID specialist, Chennai Apollo, I followed his discussion.
Yeah, that's
even the overall dengue death rate has increased in this epidemic this year. So last year almost we have managed many cases, but no death as what we are seeing right now. So it's all because of that new serotype. So we need to give focus in the early management is very important, rather than waiting the things to get worse.
Even the patients come to OPD with dengue positive and fever. We told our consultants to admit the patients in ICU, not even the ward also.
Yeah, in our previous discussion also, Dr. Srinivas well said that all patients better to admit in the ICU itself, initial 24 hours resuscitation, everything is taken care, rather than putting them in the ward with reasonable platelet count initially, then deteriorated over 6 hours, shifting to ICU, losing the battle, may not be correct.
Yeah, it's happened already.
Right. So next week, tropical syndromic approach of tropical fevers will continue.
Unless David does not come again with another important discussion. It will be
no more discussion, sir. I request Dr. Satish to give the presentation in the next week. Thank you all. Thank you for your active participation.
Thank you.
And, you share your experience, and we will meet in the next Thursday. Thank you.
Thank you all.
Thank you.